I grow up, I want to be a ballerina. I want to be a doctor. I want to be a teacher because they know a lot of awesome stuff. They get to dance all day for their job.
I would hope kids get better and make everything super fun.
I'll stand in front of the class and make sure everyone knows what I know. They can stand on their tippy toes.
I'd have a cool waiting room with games, toys, and a huge TV.
And twirl around like magical princesses.
If your child is sick over and over again, it could be PI, a defect of the immune system that affects millions. Early testing can give children a chance to dream.
And when I'm a teacher, my favorite subject will be recess.
And I'll give every kid a cherry lollipop because that's the best flavor.
I can't wait to grow up because then I will leap for the stars.
Jeffrey Modell Foundation, helping children reach for their dreams. Visit us at info4pi.org.
Hello, everybody. I'm Sonia Balboni with the PPTA. I'm very pleased to introduce to you today a panel focusing on patient access to care in Latin America. I think this is actually the first time that PPTA has done a Latin America specific panel. Our first speaker is Matthew Hotchko. He is the president and CEO of the Marketing Research Bureau since January 2020 and is a noted global expert on the plasma industry. His organization's aim is to provide accurate data and forecasts to the plasma collection and fractionation industry, and he's a frequent speaker on industry topics at international congresses. And he's been with the company for 10 years. Please go ahead, Matthew.
Thank you, Sonia. Yes, it's my pleasure to be able to speak to you on the Latin American situation. And if we were to characterize the history and present situation in Latin America as a Shakespearean drama, it would be clearly classified as a tragedy. And you will see in a moment why. First off, I'd like to just state that most of the data that's presented in this presentation is collected by my company, Marketing Research Bureau, and it is copyrighted. So overview, I will just briefly go over some of the plasma protein sales and compare that with the global, go over plasma fractionation in Latin America and compare that with the global growth. And then as you'll see, it's slower in Latin America, hence the tragedy known genre, and go over some reasons for that. And then I prepared a visual history showing you the fractionation plants that existed in Latin America and what has happened to them over the last 30 plus years, and then conclusion suggestions. With that, let me just share with you the global picture of plasma protein sales. These are just sales of proteins derived from human plasma. Over a 22-year period, 7.4% average annual growth. Just point out a few things. One of the most notable ones is that in that 22 years, you see that IVIG and subcutaneous IG has grown tremendously, been the driver of the industry. All the proteins have grown, some more relative to others. The 2020 market was about $28 billion globally, according to the data that we collect. So let's look at the Latin American portion of those plasma protein sales. And I want to compare a 20-year time period from the late 90s, 1998, to 20 years later, 2018. In 1998, Latin American plasma protein sales was 5.7% of the global protein sales. Total sales at that time were $6 billion. And then we move forward 20 years later, and the sales in Latin America of plasma proteins has shrunk to 3.6% from 5.7%. The overall market has grown tremendously. It was 24.1 billion in that year. But the proportion going to Latin America has declined significantly. Looking a little bit more at the sales per major product category of plasma, I have here a 21-22 year spread between the Latin America and the worldwide based on the years that we collect data in different regions. And what I have is the growth in that product category between the first year and the second year in Latin America and worldwide. And you'll note that first, IVIG and subcutaneous IT has grown the most in the past 20 years, both in Latin America and worldwide. But the worldwide number grew faster. The same is true for albumin. Actually, the worldwide albumin sales grew almost twice as fast as that in Latin America in the 20-year period. Plasma-derived factor VIII was the same growth rates, and plasma factor IX actually grew faster in Latin America than worldwide. That's largely attributed to the switch to recombinant factor IX products in many of the high-income countries. But then hyperimmunes show the same trend as IVIG and albumin, and the total overall, as you can see, lower and slower growth in Latin America than seen in the worldwide growth. And to put it in another form, the share of plasma proteins going to Latin America in this 20-year period from 1998 to 2018 shrank 37%. So basically, Latin America lost 37% of its plasma protein sales market share in a 20-year period. And just for those who are thinking like, well, maybe the population shrank in Latin America, the chart on the right shows that the Latin American population is very constant, 8.4, 8.5% of the global population during that period. So to have a shrink of 37% of relative share of plasma proteins over 20 years is really emblematic of a market that has not gotten its share of the growth in the industry. And so there's a lot of reasons for that. And I'll briefly go over a couple of these reasons. And there's there's more than 20 countries in Latin America. They all have their different history and different situations. I can't go into all of those, but I just broadly categorize these in kind of 8 main reasons. And I'll briefly touch on these, including the reimbursement frameworks, the reimbursement levels don't always reflect the unique costs that plasma proteins are. And so therefore it's not very attractive markets at times. Governments, some of the governments more than others, but many of them have not paid attention to rare diseases as much as more endemic or common diseases that they're trying to tackle in these low or medium income countries. Also, there's a couple of plasma specific reasons in the industry, including just the lack of using of recovered plasma that is collected part of Red Cross and blood collection agencies across the region for either quality, logistics, or just lack of government kind of initiative to do so. There's also been a prohibition on remunerated plasma, and you'll hear more about this in the next presentation by Dr. Antonio. And that's prevented or stopped commercial operations that used to operate in the region. There's no strong regional or national plasma fractionation companies in the region that can promote the industry, promote plasma collection, promote the job benefits that these companies contribute to the regions they operate in, and consequently, and as a result of plasma issues, most plasma centers have closed, as you'll see in a visual presentation shortly. Limited public awareness of the and weak patient groups, not everywhere in Latin America, but weak patient groups in a number of places. And while that's improved, as you'll hear in the next 2 presentations, historically they've had a tough time fighting for resources to treat those patients. And finally, brain drain or immigration to the United States or Western Europe, which really has caused in a number of countries, especially the lower income countries in the region, disruptions, lack of continuity in established organizations, and created instability. So with that, let me shift away from plasma protein sales and shift to plasma collected and used for fractionation, for the basic source material for all the proteins these patients need. I think most people listening to this presentation and at this meeting is well aware that the United States in North America, which is almost all the United States, collects 2/3 of the world's plasma used for fractionation, data that we collected in 2019. And then I'd like to point out that Latin America, on this pie chart on the left, is the 0%, not the 1%, that's Middle East, 0%. And that's rounded, so it's really 0.2%. of the plasma origin in 2019 came from Latin America. Remember, 8.4% of the world's population is there, 0.2% of the plasma came from that region. That's a huge imbalance, and there's a lot of reasons for that, and it's very unfortunate. So if I look at plasma fractionation trends in Latin America, you start to see maybe the first act of the tragedy, which is from 2010 to 2019, there was a 68% drop in plasma fractionation. So it was pretty low in 2010 at a little over 500,000 liters. And then through reasons that you'll see in a second, it dropped by 2/3 to just over 170,000 in 2019, and it dropped again in 2020. So it's going in the wrong direction, because globally, the chart on the right, you see globally, of course, the plasma industry has grown tremendously in the last decade, 109% increase in plasma fractionation over a 9-year period. So Latin America is certainly bucking the trend and going in the wrong direction when it comes to the source material for these important plasma proteins. So with that, let me show you this kind of visual map-based presentation of what's happened to all these fractionation plants. Why has 2/3, more than that, of the plasma disappeared just in the last 10 years, and even more since before then? So first off, in the 1990s, and if you haven't been in this industry a long time, you probably didn't know that. I didn't. There were 13 fractionation plants in Latin America. They were all over. There were several in Brazil, several in Latin America, or Central America, and others in South America. And the names are listed here and the years of operation. But then if we go to the year 2010, let's see what happened. Starting in the late 80s, some of the smallest plants closed. This continued in the 1990s and then into the 2000s. And such that by 2010, there were only 5 fractionation plants still in operation. And most of those plants that closed were small. They were really attached to one blood collection center or a university, but a couple of them were national in character. So let's go towards the situation today. So we saw that we went from 13 to 5 in a period of a few decades. So there's been 2 plants that have been completed, but neither are still in operation. So one in Mexico and one in Brazil. So those are in gray here, so you can see that they're not operating. One plant, Hemophilia, famously has been under development for decades, and it still is not finished nor working. There are 2 plants currently active. One, Probifasa, which is owned by Aquapharma and Hemoderivados. But Probifasa is, 2 plants closed recently, one in Cuba and one in Venezuela, and there are 2 plants still operating, but the one in Mexico is really just doing bulk processing, it's not doing full fractionation. And so today, in 2021, there's 1 plant that's doing plasma fractionation in Latin America, just 1. And this is really, the climax of the tragedy, to go from more than a dozen to 1, a fairly small plant of less than 200,000 capacity for an entire region. And there are a lot of reasons. Each country has its own different story, but there are a couple of categories that I'll just briefly discuss. And then there's related issues across the region that maybe can be addressed. First one would be a lot of the plants were small. They couldn't keep up with the increasingly stringent viral inactivation and good manufacturing practice requirements. They couldn't raise the millions of dollars needed to keep the plants up to date, so they simply closed. And very important change in some of the countries, including Mexico and Brazil, was the prohibition of compensated plasma. And that caused both public and private companies to close because just the source of plasma just dried up. And so they can't operate if they have no source of material from which to fractionate. Inflation has been a problem in several countries. There's been high inflation and even hyperinflation. And the companies became essentially financially insolvent due to fixed revenue based on selling to the government, but higher and higher costs due to hyperinflation. Then there's been management challenges in a couple of the companies that have resulted in various challenges of continuing business operations, causing the closing of those. And then lastly, and another important reason is that in a number of countries in Latin America, you've switched from leftist governments to right wing governments. And when the governments switch, whatever policies before are canceled and new policies are put in place. So if the previous government was in favor of fractionation plants, the next government won't be. And this kind of seesaw shift with every election or two doesn't create the kind of long-term environment that companies want to operate in, or public companies can really be built and managed. So a lot of reasons, and those are a couple of the main ones, the categories. But so with that, I'd just like to do 3 conclusions and 3 suggestions. First conclusion is that plasma protein sales have not grown as much as other regions. In the past 20 years, we saw that 38% drop, 37% drop in relative market share for products going to Latin America. And even more so, the volume of plasma fractionated dropped even more, a 68% drop in the last decade in plasma fractionated in the region. And as a result of just one fractionation plant operating in Latin America today in Argentina, which is a lot less than there was in the past. So what are some suggestions? How can this change? How can we change this tragedy to a hopeful situation? We'll hear more in the next presentations, but I will suggest 3 things now, which one would be to have laws changed so that the collection of sourced and recovered plasma can be used for plasma fractionation in all countries, because it's not at the currently allowed either source or recover, or sometimes both. And I would even say to really make it a biggest impact as possible will be allowing import or export of plasma, because none of these countries are very small, especially in Central America. And so they need to be able to export their plasma to maybe a fractionation plant in the region or elsewhere. Promotion of public and private partnerships or commercial plasma fractionation companies would do a lot to promote economic benefits, the jobs created by fractionation plants, so people don't have to move to United States or high-income countries after graduation. They can work in the biotech industry in their own countries. And then consider remunerated plasma. It existed in the past in several countries. There were some abuses at the time, but following the models that North America and Europe have developed for remuneration could provide a lot of benefits, including attracting and retaining donors, boosting their incomes, and providing more plasma that this region desperately needs. So finally, I'd like to say thank you for my presentation. And before I close, I'd just like to specifically thank 2 people. One is Patrick Robert, the former president and owner of the Market Research Bureau. He's my mentor. I want to thank him for going over hundreds of pages of MRB archive documents to create these history of plasma fractionation in Latin America. And secondly, a new employee, Dana Milosevic, who gathered a lot of the plasma protein sales data, which you saw from our recent Latin American report. And with that, I'd like to say thank you. You can certainly contact me with the information here.
Matthew, thank you for that very interesting presentation. It really sets the stage for what's coming next. We have 2 individuals who will be talking to us from a patient and clinician standpoint. First, for immunology, we have Professor Antonio Condino-Neto. He is Professor of Immunology and Experimental Medicine at the Institute of Biomedical Sciences, the Universidad of Sao Paulo. He's a former president and active board member of the Latin American Society for Immunodeficiencies, and he has authored over 170 peer-reviewed publications. Basically, Professor Condino-Neto has way too many accolades for me to describe here, so I would like to refer you to the conference website where you can learn more about him. Also, before Dr. Neto begins, I'd like to ask you, if you do have questions, please remember the Q&A function is available, and we'll be able to answer any questions after the talk. So go ahead, Dr. Antonio Condino-Neto.
Thank you very much, Sonia and PPTA, for this opportunity to share some of our experience regarding plasma-derived proteins, especially in the immunology field. So we have just seen from Matthew's presentation the decrease of plasma collected in Latin America. So I'm going to show you something different. If you look here, Latin America is the most promising market in the world, demanding immunoglobulin and other plasma-derived products. If you compare 2013 and 2018, we have grown about 64% the number of diagnosed patients, according to the Jeffrey Model Foundation. And as well, regarding the immunoglobulin, we have grown in these 5 years 123% of the immunoglobulin prescription and consume. So that means we have a long-term educational program and based on the Jeffrey Model Centers and on the Latin American Society of Primary Immunodeficiencies. And that prompts us to increase that diagnostic rate and increase the demand on immunoglobulins and other plasma-derived products. The most recent distribution of the LASID registry, these data here are available at the LASID registry website. This is public. So we have almost 9,000 registered cases. Potentially, we should have around 50,000 cases. But just to date, we have registered over 5,000 patients with predominantly antibody deficiencies. And if we put together with the combined immunodeficiencies and other syndromes associated with immunodeficiencies, we will get a number of approximately 7,000 or 8,000 registered patients requiring immunoglobulin. So that means around 70 to 80% of the available diagnosis already made. If we put that on a perspective of a potential market, we should have in Latin America more or less around 35 to 40,000 patients requiring immunoglobulin. The diagnosis we have established, most of them are specific antibody deficiencies, BTK deficiencies, common variable immunodeficiency, and other diagnoses that are available in the public site of our LASID Society. I live in Brazil. It's a big country with over 200 million inhabitants, more or less the size of United States or Canada, but we have 7 times more people in Brazil than in Canada. And we have increased our consume over 200% of immunoglobulin. Particularly in Brazil, the Brazilian group of primary immunodeficiencies play a very strong educational project in over 20 years. And the end up result is the increase of the diagnosis number. And that became more intensive after the implementation of the Jeffrey Model Center in São Paulo, which allowed us more funds and more technology to find those patients in the population. Here is a number of the MRB that Matthew just showed. So also confirms the increase of the market. But if we look on the SUS data, which is the official data of the Ministry of Health, the increase is more than that. So what happens? If you look on this map, is the PPTA collecting centers. Actually, it's not a problem of Latin America, the lack of plasma. It's a problem of the South Hemisphere. So in Latin America, we don't have collecting centers. In Africa as well, and most parts of Asia and Australia as well. So something happens that all of the industry is that located in the North Hemisphere, most of it in the United States and Europe, and there the plasma is collected. So there is a law. The law allows to collect the plasma and produce the medications. But here, at least in most of these countries, and I would say for my country, we are 200 million inhabitants population with enormous potential to collect and share that plasma. But we have to update our law, and I will discuss that soon. There are some bottlenecks here. So the collection of suitable plasma, the adequate storage for collected plasma, adequate fractionation procedures, and even if all patients are correctly diagnosed, the national product will not be enough according to the current potential and current perspective. So what happened here? Plasma is the leftover of blood donation process. So people will go to blood centers to donate blood for medical emergencies. And the leftover is transformed into plasma, is stored as plasma, and then it is directed to Hemobras, which is a government company located in Pernambuco state near Recife, where plasma fractionation should take place. So the program is delayed, and that is a huge bottleneck. The other thing is, if we go on the South Hemisphere map, where there is nobody collecting plasma, we have to remind that nowadays, COVID experience is there to show that all of those tropical diseases and infectious diseases may travel to the several continents of the world, and should be useful to have plasma from Brazil and from other Latin America or even African countries with antibodies against yellow fever, chikungunya, dengue. And we have to remind that São Paulo city, where I am, was this week declared the world capital of vaccine COVID. We have the highest cover ever in the world for this week for the number of people vaccinated against COVID. This is a huge accomplishment and shows that in our country, vaccine is very welcome, very well accepted by the population. It's a culture here in our country to go for vaccines. The public program exists in the last 50 years, and Brazilians love vaccine. So I would say that in more 1 year, we should reach almost 100% of the population vaccinated. I myself already received 3 shots of vaccine. So we are starting to revaccinate people from this last year. And the pandemic is fortunately going down. So what a treasure should be if we could make available my plasma and all of the other plasma from Brazilians with a lot of anti-COVID antibodies for the plasma industry. That should be precious. Our Constitution, the last one, the Article 199, was dated to 1998, so more than 20 years, and should be updated. So what says there? So there is a restriction for the commerce of organs that was built to avoid organ traffic. And blood, by law, is considered an organ, so it's forbidden to sell blood or any blood derivative. So this is a major bottleneck. I have a little bit different idea of why we do not collect plasma. First, because the law does not allow. It's not because people do not want to comply. The vaccine, the COVID vaccine campaign is there to show that we are very compliant with public health measures. The coverage of vaccines in Brazil is fantastic. So if we do an educational campaign for people donating blood or plasma, should be very well received. And I don't think that money should be the principal attractive, because people is going to take vaccine not for money. So here things work differently. And we must first fix the law, and then we need investment. So if the companies want to fractionate plasma, should be nice if the companies invest in plasma collecting centers in this country or throughout Latin America, and then we can discuss the logistics, how to fractionate that plasma, or even build plants in this country or in the neighboring countries to produce immunoglobulins here, or even to pool our plasma with plasma from other parts of the world and share the immunology experience. That should be much more advanced. So, plasmapheresis here should be developed. We do not have it available, just some places for medical purposes inside hospitals, but we do not have plasma collection centers, and that kind of investment should be made. Fractionation overseas, yes, should be something useful, but it will not solve the problem completely. And what we have available here, which is the model of blood donation and plasma fractionation in just one government company, yeah, should be nice when it starts working completely, but it will not be enough for 200 million people. So I would like to thank you for your attention. I'm here to discuss and answer questions, but my message is what we need in Latin America is to update the law in order to allow plasma collection, and we need investment, serious investment, in order to make all of those products available for us. And I'm quite sure that people will be eager to donate plasma, and the money issue is not that important as it is in other countries. Thank you.
Thank you, Professor Condino-Neto. That was very interesting. You certainly are selling the case for Brazil. And next, I would like to introduce Miguel Izquierdo. He is Regional Manager for Central America and the Caribbean at the World Federation of Hemophilia. He received his law degree and Master in Humanities and Law from the Universidad Michoacana de San Nicolás de Hidalgo. And as a member of the hemophilia community, he has 14 years experience leading projects with public and private partners. With the National Hemophilia Organization, his experiences include patient access coordinator, leader, and founder of the National Youth Training Program, and participant in the creation of the Interinstitutional Care Handbook with the Mexican Secretaría de Salud. And he was the president of the Federación de Hemophilia in Mexico from 2015 to 2017. Please go ahead, Miguel.
My apologies. After all of this time, I cannot remember to unmute myself when I'm about to speak. Thank you very much, Sonia. Thank you for the PPTA. Thank you for the other panelists. Very interesting the topics that they mentioned. And in my case, I'm going to talk more about the importance of access to care for the patients. From the patient perspective, the World Federation is a patient organization for the most part, and primarily we want on basically one thing that leads all of our objectives and projects, and that's treatment for all. We want patients with a bleeding disorder or people with a bleeding disorder to have a full and productive life, to be able to sustain themselves, their families, and to be able to get involved in the society as anybody else. For this, it's important to have access to treatment, obviously. Just to give a short heads up or a summary, we have 147 national member organizations. These are for 147 countries or territories, and we are very happy to have these 7 new organizations incorporated in 2020. Even with the global pandemic, we were able to increase the number. We have 20 organizations that speak Spanish in America and 7 that speak English. And you can see a little bit of how we are distributed. And also, and I'm sorry for this because the 2020 global survey data was just published last week, so we didn't have time to update the presentation. But if the world the world is run by data, and we need to be able to identify how many people have a bleeding disorder, how many people have hemophilia, other bleeding disorders, and also to be able to report and see how access to treatment, access to care is diagnosis is expanded through the world. So every year we do this huge exercise of collecting data from patient organizations, from doctors, from authorities, and we present this in the global survey. And if anybody wants a copy of this is available for free at the World Federation of Hemophilia webpage, and even you can reach out and I can share with you the link. This is published in English, French, and Spanish, and we have also interactive data. And if the world was a country, we will have this per capita use of factor 8 and factor 9. When we talk about per capita use, is basically the full amount of units plasma-derived or recombinant use in the purchase or use in general in the world or in a country, divided by the number of inhabitants. So let's say if a country has 1 million inhabitants and they purchase 1 million units, we divide it and we have a 1 unit per capita average. And what we want to do with this is to have a way of measure the access to care and the importance. And different publications have established that 1 unit per capita is the threshold to guarantee that the patient can move from childhood to adult age. We are not talking about quality of life or joint health, just being able to keep patients alive and move from childhood to adulthood. So in this sense, we could say that the world has changed and now there's this access. But if we go basically to the world, we have another issue, and that's diagnosis of patients. How many patients can we diagnose accurately and opportunely? How many patients and how soon can we diagnose the patients so they can receive the adequate treatment? And we can see in this graph that the average for the region, for the continent, is 31% of patients that we have that we would expect that are diagnosed currently. And we have some countries like Barbados, Venezuela, Chile, Belize, that have very high rates of diagnosis. Some of them are because they are small countries like Belize or Barbados, but some others are because they have a very good public diagnostic system. And even Venezuela, with all the situation that they have faced in the last years, they are able to sustain a very good registry, because this has to be a public policy supported by the patient organizations. And why it's important to identify patients and to properly register them? Over the years, we have identified that the access to care or the consumption of treatment is very well, it's colligated with the number of patients diagnosed. So we can see in this graph how the access to care or the consumption of factor has increased over the years, and the correlation is 0.92, which means that it's basically one more patient means more consumption of product. And this is important because sometimes we think of these two areas as separated. Diagnosis, yeah, that's done by the lab, and that's important, but we want to have access to care. But if we don't do this part from the start, and we don't do an organized and very well structured process for identifying the patients, properly and adequate diagnosing them, so we know if they have hemophilia A or B or von Willebrand, and what type of von Willebrand they have, we cannot start advocating for care. And if we go directly to the factor VIII consumption in Latin America, we can see that we have most of the countries don't exceed this 1 unit per capita threshold, despite of the efforts by the World Federation of Hemophilia to donate large amounts of products, recombinant plasma derived, standard half-life, extended half-life. We try to reach out to all these countries that have issues or problems accessing care, but obviously it's not enough all the time. So then, but we can see that the countries with the higher rates or the higher consumption of products are the ones with the stronger registries, national registries, and that have a policy or that have a way to find the patients, direct them to be diagnosed at a lab, and then to be registered. And we can see the high rate of consumption in these countries. So in the end, when we talk about this comprehensive care, or when we talk about access to treatment, it's not, we identify that that's not the only thing that can improve the quality of life of a patient. And we need to talk about comprehensive care, or and for this we have identified a model that can lead us to improve the quality of life of the patients, and also to support the healthcare professionals. And this is 6 pillars that you can find here. And obviously, if you need more information, I can share that. But I'm going to talk mostly about the medical expertise. So when we talk about the medical expertise, laboratory diagnosis, and medical treatment, we talk about the importance of having this comprehensive model created and expanded and sent to the patients, distributed among the country, so the patient can benefit from them. The biggest or the most important tools that we have for this matter is the hemophilia and von Willebrand treatment guidelines. For the hemophilia treatment guidelines, we have this. This is the third edition that was presented on 2020, and these were developed by medical professionals from all over the world. And for this time, we have the input from patients. It's the most current and best recommendations. And we emphasize the use of prophylaxis, low dose or regular, the importance of multidisciplinary care teams, and the evaluation of the outcomes of care. Because obviously it's important to have access to care, but if we cannot measure it, if we cannot see the reduction in bleed rates, if we cannot see the increase in joint mobility and joint health, it's going to be very complicated to make our case. So again, you can download this for free from the World Federation of Hemophilia webpage. And then we also have the ISTH and HFWFH ASH guidelines. These were presented in 2021. This is for the management of von Willebrand's disease. This is for diagnosis, treatment, management. And this is a very interesting opportunity in collaboration, because here we had patient organizations and medical organizations working together to develop the best way or the best models for care of the patients with von Willebrand. And again, we want to create this urgency and this need for prophylactic treatment for von Willebrand. We know that in the world it's very complicated to gain access for the people with von Willebrand disease, women and men, to have access to prophylactic care, because usually it's confused with hemophilia or with other situations, and this leads to a blockage or a problem with access to care. So you can see the guidelines for the management, the diagnosis. We have some resources for the training of professionals. We have information for the patients, and you can find it there. But the most important part from both the von Willebrand and hemophilia guidelines is that we want to be part of this conversation of thinking about comprehensive care for the patients, thinking about the importance of early diagnosis and accurate diagnosis. And in this sense, it's very, very important for us to share. So basically, we need to ensure the same standard of care for everybody with a bleeding disorder. We need to be sure and provide the care and provide the training for the healthcare professionals to be able to treat the people the same, either if it's in Belize or Brazil or the Netherlands. We want the same standard of care for everybody. These guidelines can be a starting point for patient organizations, for healthcare professionals to develop their own national guidelines, their own standards of care in their countries. Also for the national member organizations or the patient organizations to continue this advocacy effort to procure for better care, for more access to this care, and for early access to this care. It's important to have access to the care within the first 2 hours of a bleeding, or to have it a prophylactic treatment. So we need to be able to grant access for the patients close to their home, close to where they live. And in the end, we are trying to share this information. We have a mini webpage with videos and with information that can be shared among patients and among non-specialized healthcare professionals, so everybody can get this kind of information. But in the end, when we talk about access to care, the importance of care, this what you can see in your screen is why we do this. It's because we see the healthcare professionals, we see the medical authorities, and we see the patients as one, as a community. We want to bring everybody together. We understand that it's also complicated for healthcare professionals, for medical authorities, sometimes to provide the access of care that the patients need. So we need to be all together and join forces and work together, aiming to a better care for patients with a bleeding disorder. And with this, I will close my presentation. So thank you very much, and I will listen to your questions.
Miguel, thank you very much for that. I think now we're going to move into the Q&A phase of our panel, featuring all of our panelists. So I'd like to start, we did receive a number of questions. I'd like to start with one. Tell me, I guess this is more for Miguel and Professor Condino-Neto. Tell me a little bit about how political changes affect access to care in your countries, if you could. We sometimes get calls from different organizations about such issues. Do you feel that that's a factor in access to care, primarily in Latin America?
No, I would say for my country. In Brazil, there is a public health system covering for 100% of the population. And in parallel, there is a private market with insurance companies covering 25% of the people. In other words, there is double coverage for 25% of the population. So what happens according to the politics is that the law here, the Constitution says that the health system, it is mandatory. All of the citizens have the right to receive health care, and it is mandatory that the government will provide that. So private medicine here is optional. The medicine is socialized. According to the government, there are some governments that will put extra money in the health system compared to others. So that is what it will vary. There are some governments that will make more investments, so the system can be perfected, can be better, and other governments put less money. For example, this year in Brazil, for the pandemics, although we have a controversial president, the technical part of the Ministry of Health put a lot of effort to give the vaccines, the COVID vaccines, to the population. So a huge and heterogeneous country like Brazil is percentually more vaccinated than the United States. And capital in São Paulo is the world capital of the COVID vaccine, despite of the craziness of the politics. So we have the investment for the vaccines. The other thing that happened this year for Brazil is the approval of law making universal the newborn screening for over 50 metabolic diseases and inborn errors of immunity. That's a huge improvement. We already started. In the city of São Paulo, we already screened over 100,000 babies and identified 3 kids this year. Nobody was expecting this. But the city of São Paulo decided to put that investment. So we have numbers here that even more developed and rich countries do not have. So to finish my part, the public health here is mandatory, and it is in the Constitution. There is mandatory money to put in that system. If you have a better government, they will put more money. So what happens here is that we have a controversial president saying a lot of, I would say, not appropriate things, but the technical part is working very well, and they are not political.
All right. Thank you, Antonio, and congratulations on the newborn screening. Miguel.
Yeah, very quickly, I think that the main problem with political changes in the region and within the countries is that a lot of times there's no official regulation regarding the care for people with a bleeding disorder. So there's no national hemophilia or bleeding disorders act. There's not an office that takes care of the patients with hemophilia from Willebrand, etc. So the main problem is that when a lot of times when we get a success, when we obtain some care or some kind of improvement of care with a new government, with a new leadership in the Ministry of Health, we can see these efforts diminish and affected. So one of the key points that we have seen for this is very active organizations with a very strong medical leadership working together, and that they can continue these advocacy efforts. And obviously having national guidelines, national protocols of care, it's very important, because then you can standardize the care. And even if the government changes, you have access to certain level of treatment that you can provide for the patients.
Thank you, Miguel. We also have a question for Matthew, which I'm going to combine, I guess, two questions into one. There is the question, how many centers are there in Latin America which are operated, collection centers, which are operated by private companies? And then combining that with, if you could talk a little bit about contract fractionation.
Yes, yeah. Well, as you saw in Dr. Antonio's presentation, there's not any centers that are commercially operated in the whole of Latin America today that are source plasma. Zero, that's an easy answer. And then contract fractionation, yes. Most of the plasma that's used, the under 200,000 total that's in Latin America last year was contract fractionation for the most part. Last year, Brazil also announced a contract fractionation agreement with a global company to again start fractionating some of its plasma. We'll see how high the volumes go. So that's definitely a viable option, but only 4 or 5 countries out of 20 plus even do that. So there's a lot of room for more countries to participate, especially if they change their rules and laws to allow for an export of plasma to another country for fractionation.
All right, thank you, Matthew. So I guess this question was phrased to Professor Condino-Neto. It, I think, might also apply to Miguel. So these are countries in Latin America. We've got Brazil, Mexico. You know, in Brazil, as you said, Dr. Condino-Neto, they straight out prohibit plasma collection. In Mexico, I think it's prohibition of compensation, which makes it hard to collect source plasma. So what do you see as main influencers contributing to changes in law in regard to plasma collections? And is it WHO, patient organizations, physicians, others? And I'll add, there was another question from the audience asking if this is something, you know, is this something we should increase our advocacy with the PAHO, which is the Pan American Health Organization. So go ahead, Professor Condino-Neto. And you're on mute.
Yeah.
Okay.
Yes, Sonia, we have to increase our advocacy. And, you know, our experience here with the newborn screening program, my perception is that the medical societies we have made a lot of advocacy and scientific campaign, but we found that when patient associations and the people themselves started to claim for that program, and they contacted directly their representatives in the Congress and Senate, and that was transformed. That became a kind of the first lady accomplishment. It was easy to approve. So when doctors say things, I think our role is to give the scientific basis for the people to claim it. And we have to do it at the legislation and at the law level. Here in Brazil, the Supreme Court works a lot. And sometimes the ministries in the Supreme Court, when they starting demanding certain things, then things start to move faster because they obligate to do that. So we need the three powers: the executive, which is the president, the governor, and the mayor. We need the legislative, the Congress, the City Hall, and we need the judiciary, the law, the Supreme Court, and the respective courts working together. The doctors will provide the scientific basis for that claim, and the people will have to move and contact those powers, and we work together. As well, it is very important that the plasma industry, here we have the Sindus Pharma, which is the kind of the local PPTA, okay? The Sindus Pharma represent all of the pharmaceutical industry. They also have their possibilities to claim the same thing. So we have to work together. It's not just a matter of the medical society. Everybody has to work together and make a people real claim. If that is made, it will work.
Thank you, Professor. And Miguel, your take on that?
As patient organizations and especially the World Federation, we don't distinguish, or we consider that treatment is, we don't specify or provide preference for plasma-derived or recombinant one. We consider that treatment must be accessible for everybody, and that as long as it's safe, and it's we need to grant access to the patients. Being said that, I think that the most important part of these efforts is the inclusion of the patient community in these kind of efforts. And as Dr. Neto said, we need to have the patient organization and the patient community, along with the medical community, to join forces, to be brought together and to participate in this effort. From their perspective, and I would say from the patient perspective, of safety of the recollection of the products, and also to identify the best way for the community to understand this. There's a lot of misinformation sometimes. We know that there's misconceptions in many of the in the web, let's say, in the social media, and sometimes this creates a problem. So that's why we need a strong collaboration with the medical community, that with this scientific information that Dr. Condino mentioned, we can have this collaboration and we can have a more accurate information for the patients. But I would say focus on the safety and the involvement of the patient organization, so they can help with this advocacy that sometimes is not as easy as it would seem, to bring all the community together, and legislators and government.
All right, thank you, Miguel, for that. Unfortunately, we are out of time. I've been messaged by my PPTA colleagues that it's time to end our panel, but I would like to thank all three of you for your insightful, information-packed presentations. And yes, we will continue to advocate for access to care in Latin America and throughout the world. Thank you also to the Jeffrey Modell Foundation for sponsoring this panel. And right after this, and just before the break, we're going to be showing some patient videos, little vignettes that discuss how patient advocacy can be successful. So thank you, everybody, and enjoy the rest of the afternoon.